Good afternoon and welcome to today's IAC webinar, Diuretic Renal Scintigraphy in 2020, Where We Are. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click this tab for links to today's handouts, which include a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the Voice Category A CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and SNMMI. And now I would like to introduce today's guest presenter, Dr. Kevin Banks. Dr. Banks is a diagnostic radiologist and nuclear medicine physician at Brooke Army Medical Center in San Antonio, Texas. Board certified in diagnostic radiology and nuclear medicine, he serves in the Department of Radiology at San Antonio Military Health System and Health Education Consortium as Program Director for the Nuclear Medicine Fellowship. He is Assistant Professor of Radiology and Nuclear Medicine at the Uniformed Services University of Health Sciences, and we are happy to have him with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Kevin Banks. Doctor?
Good afternoon, everyone, or good morning, depending on where you're attending us. I appreciate everybody taking time out of their busy days to participate in this webinar. Before I proceed, I do want to thank the members of IAC for inviting me to present this material. I think it's a wonderful topic, and it's something I have a lot of interest in. And in particular, I need to thank Drs. Leonie Gordon, Miss Mary Beth Farrell, and Miss Maria Costello, who all have supported this research and also kind of served as an inspiration for it. If you had the opportunity several years ago, they wrote an article about gastric emptying and practice patterns, and it was wonderful and kind of served as the inspiration for me to kind of look at renal scintigraphy and practice patterns, kind of finding out where we are. I've always found it interesting to look at how practices vary from institution to institution, country to country, and things of that nature into outpatient setting. And so that's why I want to talk about here, in addition to kind of what are the guidelines out there from our national societies, such as the SNMI, and also look at best practices. I have no disclosures. The learning objectives for today, you can see there, I want to review the current role of diuretic renal scintigraphy in patient care. How are we using it? Look at the guidelines, consensus statements for its performance and interpretation. And then I also want to compare the various protocols and reporting approaches that are in use in today's practices. And for learning objectives 2 and 3, I'll kind of do those both simultaneously throughout the talk. I'll be jumping between guidelines and how we're doing things, kind of comparing back and forth. And I want to emphasize that this is really an assessment of how things are being done. It's not necessarily an endorsement for what is the absolute best way or the only way, because you'll see from this talk that there is a lot of variation out there, and there's a lot of variation in what's recommended and what the research supports. And so it makes it such an interesting topic, and a topic I think is ripe for future research. So current indications for renal scintigraphy cover these 5 things. You can see there urinary tract obstruction is by far the most common indication we get for these studies. Along with that, congenital and acquired renal anomalies, renal allograft, perfusion, function complications, then renal vascular hypertension, pyelonephritis, renal cortical scarring. And really, I'm going to be focusing here on the first 3, which are all part of diuretic renal scintigraphy. And really, it comes down to that topic of urinary tract obstruction. When we're looking at congenital and acquired renal abnormalities, it's usually because we're worried, do they have obstruction? Same thing if we're looking at transplant and we're using renal Lasix, we're wondering, is there obstruction going on there? Is there possibly a stenosis at where we did the anastomosis for the renal pelvis or the ureter and things of that nature? So it all comes back to urinary tract obstruction when we're talking diuretic renal scintigraphy. Our goal is real simple. We want to differentiate between obstructive versus non-obstructive hydronephrosis. There are some much less common things such as the wandering kidney, the tonic kidney that we think may be intermittently obstructing and therefore not necessarily presenting with hydronephrosis. But the vast majority of our patients do present with some sort of anatomic finding on ultrasound, CT, things of that nature, of a dilate collecting system. And the question the urologist usually has for us, the nephrologist, the internal medicine physician is, is this a mechanical obstruction? Are we going to cause damage to the patient's kidney? These are the classic causes. It can be congenital. We see this all the time in newborns. Stricture is common. Stricture most commonly due to prior stone burden that caused some inflammation and some scarring. And then, of course, you can have tumor. Most classically, we see colorectal cancer. In women with cervical cancer is a very common cause of obstruction. And then in men, prostate cancer can also be a cause of obstruction. Then we consider this with the non-obstructive cause of hydronephrosis. You can have congenital dilatation without obstruction. They're just born. The congenital megacalycosis is one we know. Vesicoureteral reflux. Those recurrent bouts of reflux can cause, due to the inflammation and the backflow pressure and things like that, can cause the calyces to become dilated and blunted, the renal pelvis to be also dilated, the ureter to be dilated, and that can look like an obstructive process to us, and it's not. Along those same lines, urinary tract infection, that's usually much more milder. A non-compliant bladder, that should present likely with bilateral obstructive looking changes to kind of clue us in that it's something that's distal. And then, of course, prior obstruction. If a patient has a severe enough or prolonged enough obstructive process, the collecting system in the ureter may never actually contract down to their original size. They may stay dilated. And so we don't know for sure whether there's ongoing obstruction or not. And so they'll be referred to us for this test to try to tease that out. So the idea behind doing diuretic renal scintigraphy comes from the idea that under physiologic conditions, if you have a dilated collecting system, the urine, if we gave, if we used MAG3 or DTPA as a radiotracer, it could pool in that dilated collecting system, and we wouldn't know, is it staying in that collecting system either because they are obstructed, or is it just this reservoir effect? You can see there, it just kind of continues to fill up under normal physiologic conditions. And so someone smarter than myself came up with the idea, what if we can do something to increase urine production, increase flow? And that's the idea behind using Lasix or some other diuretic. And with that, if you have a dilated but non-obstructed system, then under this situation of increased urine production, you will get rapid washout of that activity from the renal pelvis. Whereas if they truly do have a fixed obstructed, then even under increased urine production settings, you're still going to have delayed clearance from that dilated collecting system and prolonged retention of radiotracers. So that's the idea. Under normal baseline conditions, we wouldn't necessarily be able to tell this in the vast majority of patients, but however, with the use of Lasix, which is known to increase your urine production 5 to 10-fold in the healthy individual, you can overcome that reservoir effect and truly tease out whether or not the patient has an obstructive process or just has some sort of dilatation without obstruction. So I like to use cases to kind of teach. So I'm going to start off with this case here of a 40-year-old female. You can see there she had a history of kidney stones. Like I said, that can cause inflammation of the ureter, can cause some scarring and fibrosis and a stricture. And so you see there in the lower left corner, let me bring my laser pointer there, you have this dilated renal pelvis here. Compare that to the contralateral side where you can see that normal renal sinus fat and the calyces are all nice and contracted down. So she was sent to us because they wanted to know, is this patient obstructed? Do they have to intervene on this patient? So this is her renal scintigraphy, and I emphasize at the top, I'll always talk about what type of protocol we're using, and we'll get into that more later, the different protocols available and what the strengths and weaknesses of those are. But this, I'm sure you're accustomed to seeing, is the flow phase, that first 60 seconds, and what you're looking for is prompt and symmetric perfusion to the bilateral kidneys. That's really the main point you're looking for. Here at our institution, the other thing we like to know is it helps us quality control to make sure we had good tight bolus, because if you had infiltration of the dose, that could skew your results, give you prolonged clearance in a potential false positive. It's rare, but it helps us know that we have a nice tight bolus. You may be used to seeing it in this scenario here, when you have the images all laid out statically. And what you can see there is that initial vertically oriented blush in the midline. That's your aorta. And to determine if something's prompt and symmetric, you should really start to see the kidneys within about 2 to 3 seconds thereafter. It's just going to be that faint blush on both sides. There's not a lot of detail, as I'm sure you're accustomed to in your clinic practice here. It's just a very simple, is it prompt and is it relatively symmetric? So after that, we go on to what I consider to be the lion's share of the study. The next, depending on which protocol you're using, this could be your next 29 minutes or it could be your next 50 minutes, depending on that. But here, what we're looking at is the function and the excretion of the kidney. The function being what's going on with the parenchyma, and then the excretion being what's going on in the collecting system. And what you want to see is rapid uptake by the renal parenchyma. It should have peak activity in less than 3 to 5 minutes. And I have to admit, I don't like the range. In my clinic, I just use 5 because, what does a 4-minute time to peak mean? It's still normal, but some people wonder, is it kind of, upper limits of normal, borderline abnormal? So less than 5 is acceptable. And it's important to know that that is true for both MAG3 and DTPA. You want to see a relatively symmetric time to peak and a relatively symmetric intensity of that. And then you want, in a normal, healthy patient, to see that parenchyma wash out. It wants to clear out. That means the radiotracer is getting passed through the parenchyma and not being held up due to some underlying dysfunction. And ideally, 20 minutes after that peak, you should have less than 30% retention. All right. And then normal renal excretion, you want to see that collecting system empty out, less than half be in there 10 minutes after time to peak. And I'll tell you, if you read the textbooks, such as the one by Dr. Mettler, he's taken that number out to 15 minutes. As long as you're less than 50% by 15 minutes, that's normal. And I agree with that. We used to say that, between 10 and 15 could be kind of in that gray zone, but really those patients, it was likely something like dehydration or something like that causing or maybe a little bit of dilatation without obstruction. So I understand that some people now reference all the way out to 15 minutes as an acceptable T1 half time to call it normal. And again, I emphasize that this patient here is normal. The other way you can look at it is if you look at the static images here, and one of the things that can be really hard without the post-processing to tell when is your time to peak, or one of the things I teach my residents here is that you look for when you first see your collecting system activity appear, like it does there in the upper pole of the right kidney, and there are calyces there. And it's usually the frame before that, so about 30 seconds before that. So on this patient, that would be right at a minute and a half. We're seeing time to peak on the right, and the left kidney maybe 30 seconds later, so they're both normal. And then you'll get a post-processed image, and this is an excellent version of what looks like normal. You see this rapid upstroke here early. You see your time to peak at about 2.5 minutes, so that's clearly normal, and then a rapid emptying of this. This is what it looks like broken down a little further, and what you can see here is your time activity curve or your renogram can be broken down into 3 phases. Now, I've annotated them here as discrete phases, but obviously there is a lot of overlap, and really what I'm emphasizing here is which phase predominates at which time point. So early on, when we're looking at our flow images during that first minute, that's your vascular phase. That's when the activity in the blood pool is the dominant part of your time activity curve. Immediately after that, you go into the functional phase, and that lasts from anywhere to 1 to 5 minutes, because that's where your peak parenchymal activity is occurring, and then you get your time to peak derived from this. And again, your vascular phase is extending out somewhere into several minutes, but it's rapidly diminishing in its impact on that. And same thing, your functional phase may start a little earlier than I indicate here. There's going to be some overlap. And same thing here when you transition from your functional phase to your excretion phase. There's going to be some overlap there. And you can see after your time to peak, that's when your excretion phase takes over. And that's the activity in the calyces and the collecting system in the ureters and things like that. When you have an idea of this, what dominates at what different times, you get a real good idea of why we do the differential function at 2 to 3 minutes. And that's because we're trying to really get the best data we can on what's going on in the parenchyma. How are those kidneys functioning on the left and on the right? And so 2 to 3 minutes is where you're kind of in that sweet spot of functional phase. You shouldn't have really anything going on in your excretion phase. If you do, it's minimal. And the vascular phase is pretty much completely over. And so it's only giving maybe a very small percentage of contribution to your measured differential function. So that's the idea behind that. And we'll talk about it a little bit more later, but there is some recommendations that you consider moving up your differential function to 1.5 to 2.5 minutes if you're using a T0 protocol where you get the Lasix up front because all this shifts subtly to the left. That hasn't been really well studied. It's just right now expert opinion says consider moving that up by about 30 seconds. So time to peak again should be less than 5 minutes, and that's really that transition between functional and excretion phase. And then some of the other things we talked about there, you want to see a T1/2 of less than 10 out to less than 15 in some new literature, and I agree with that. And then when you go out here, 20 minutes after time to peak, and I need to go back and also emphasize that for T1/2 excretion, these are both measured back to your time to peak, not back to time 0, or else you'll skew your numbers too high. This is T1/2 excretion. It should be less than 10 to 15 minutes from time to peak, and your retention of less than 30% should be 20 minutes after time to peak, not from time 0. So this is what it would look like if you're using our software here. Your split function, I mentioned, measured at 2 to 3 minutes in most institutions, should be ideally 45 to 55%, but down to 42% and therefore up to 58% is also considered within normal limits. The time to max, less than 5 minutes. So here in this patient, stone cold normal, 2.5 minutes on both sides, like we presumed from looking at the real-time images. And then time from max to half max, I've mentioned should be less than 10, no greater than 15, if you want to call it normal, and they're well below that. And then again, I emphasize, don't take this number because this number goes back to time 0. And you could imagine how if you had some borderline cases, say a max to half max of 14 minutes, if you took it all the way back to time 0, you could skew your numbers into abnormal. So I see that all the time with our staff who do not practice a lot in nuclear medicine, are not used to looking at these. They'll see the first number with half max and just report that and artificially elevate their data. And then the last one I mentioned is renal retention. You can see there that should be less than 0.3 for both MAG3 and DTPA. In this patient, it's normal. So if you want to further refine your data, you can also obtain cortical regions of interest. These are ideally the outer 2 pixels of the cortex, avoiding any activity within the calyces or the renal pelvis, which can be difficult in pediatric patients with very small kidneys. You can see there that can help you get a little bit better data on the kidney parenchyma by eliminating the concurrent data that's coming from the collecting systems. Conversely, you can do the same thing for the collecting systems in order to try to get a little bit better data about what's going on in that renal pelvis, how long it's taking to leave the renal pelvis. You can put ROIs over the pelvis. It's not perfect because obviously the kidney is a 3-dimensional structure and there's parenchyma before and in front and deep to that you're overlapping, but it does eliminate some of the pure cortical structures to help kind of refine your data further. And this one here, you can see they took it out to cover down on some ureter. You really only need to do that if you see abnormal retention in the ureter. So in this example here, this wouldn't be necessary, but if you do see abnormal retention going even down in the ureter, you do want to extend your collecting system ROI to encompass that. And then you can see here examples of your background ROIs, which is a lot of variation in how those are being done. So this is our patient. We've gone through her diuretic renal study. Everything looked normal. And sure enough, it makes sense that a month later when she came back for follow-up, that obstructive change has gone away. It's compressed down. You're starting to see the renal sinus fat again. And it's no longer that. So it makes sense. All goes together that this was just kind of a post-obstructive dilatation that resolved before she came to us for assessment. Everything was normal, and this is anatomic finding confirming that. Again, sometimes that's not the case. Now let's talk about a different protocol. Here's F+20 protocol. Some of you may be using this at your institution, be very familiar with this. So here we have a patient. We had no prior imaging, but we knew he had undergone a right-sided pyeloplasty, and the urologist wanted to know, is this working? Have we resolved the obstructive process that led to his surgery? You can see here in the first 20 minutes, the left kidney, everything looks fine. It's rapid uptake by the parenchyma into the collecting system excreting. But here on the right side, we're seeing a concerning finding. There's abnormal dilatation of the collecting system, and there's abnormal retention of radiotracer activity. So, of course, that meets criteria for administering Lasix. You go ahead and give this patient Lasix, and you can see there this dilated collecting system with abnormal retention is emptying out briskly. Visually here, this looks to me much greater than 50% leaving the collecting system over that 10 to 15-minute interval. So this, to me, in my mind, I'm expecting the time activity curves to support a non-obstructive process. So let's look at this. This is pre-Lasix. That increasing time activity curve, very concerning for an obstructive process. Anytime it plateaus or continues to increase out, it's going to be concerning. And also here you see they have an abnormal split function. Again, I told you anywhere out to 42% is probably within normal. So this is abnormal. And this is probably why he went to surgery and had pyeloplasty, because not only was he showing evidence of obstruction, he's also showing parenchymal functional decline, so that they wanted to intervene on that. Sure enough, though, post-Lasix, you see a nice rapid excretion of that right kidney. The T1/2 there is less than 10 minutes. Again, less than 10 to 15 minutes is normal, and that's great. And you don't want, the thing I always have to emphasize with my residents is when you're looking at this, you only really care about the side that you were concerned about. This curve here for the left side looks relatively flat and could be concerning to you, but that's because obviously all that activity has cleared out of its collecting system pre-Lasix anyways, and so you just need to be careful not to make the mistake of thinking that these numbers are spurious. Especially here, you look at your split function post-Lasix, it makes it look like the right kidney is providing the vast majority of the function. That's not accurate either. So in this scenario, you just want to make sure certain data needs to be grabbed pre-Lasix, such as your split function and the non-obstructive side data, and then the post-Lasix imaging is really to focus in on that kidney of concern. So in review, a normal diuretic renal scintigraphy, you should have prompt and symmetric flow, differential function at least between 42 and 58%. The sweet spot is 45 to 55%. Times peak activity, 5 minutes or less. This 20-minute to peak count ratio should be less than 0.3 or less than 30%. And then your half-time excretion should be less than 10. But again, new literature is saying you can take that out to 15 minutes and you'll be fine. And I completely agree with that. I never had a case that was at T1/2 of like 12 or 13 that ever went on to show functional decline at follow-up. So now I'm going to jump back and talk about patient preparation and start getting into what's out there for guidance and what's out there for how we practice. Because there's a lot of variables that go into a diuretic renal scintigraphy, and one of the most important variables that goes into that is patient preparation. This study starts when you make that appointment with the patient. You start giving them guidance on what they need to do prior to showing up in your clinic. Here, the American College of Radiology and the Society of Pediatric Radiology, they had a practice parameter come out in 2017. It's their most current one. They're on a 3-year cycle. So they'll revise this, I think, starting in this year and eventually publish that in 2021. But you can see here, they really only give 3 components to patient preparation: avoid fasting, good hydration, and then bladder catheterization if clinically indicated, i.e. if the patient has some sort of difficulty voiding. That's probably your neonates, obviously, and then someone maybe older who suffers from a neurogenic bladder or something along those lines where they can't void spontaneously, and you want to avoid that as a potential false positive. And the reason they say avoid fasting is really because of the hydration issue. That's all. It's not that there's going to be anything that otherwise interferes. It's just that if you fast, you tend to not take in adequate volumes of fluid. And so they want good hydration, because you need to have enough fluid available in your body to respond to that Lasix. If not, it can give you Lasix, but if you're dehydrated, and we see that a lot here at our clinic with our active duty population, especially our young trainees who, they have a very rigorous training schedule. They're training a lot in the heat here in Texas, and it's very hard to get them pre-hydrated before their appointment, because they'd rather sleep or make phone calls than hydrate. So, the Society of Nuclear Medicine, along in conjunction with the European Nuclear Medicine Association, came out with some guidelines in 2018, and they have the same instances there: avoid fasting, good hydration. They want you to pre-void. They want an empty bladder before you start to study. It makes a lot of sense, and I think the ACR needs to add that to their next iteration. What's not included in these recommendations? Well, there's nothing in here that says you need to have any labs beforehand, kind of different than when you look at, say, FDG PET. You make sure you want to look at their blood glucose ahead of time to make a decision as to whether you're going to proceed with the study. You don't have to do that here. There's no, if they're available, you should review them, is what the guidelines say, but there's no mandatory, we need to have a creatinine within 30 days. We need to have an estimated GFR within 30 days on these patients. There's no indication for radiology. Again, if it's available, they say review it, but you don't have to have some sort of preliminary imaging proving that they have hydronephrosis. You don't have to have an ultrasound. You have to CT, MR, or anything of that nature. And there's no recommendations on medications in these. So what's going on here? Well, it turns out that it's a little bit confusing, but if you go to the Society of Nuclear Medicine and you look at their guidelines and you look under renal, it actually turns out in 2018, they made 3 guidelines on the topic. So you really want to go to this one that's titled here. They have one that I was referencing on the last slide that's kind of a more generic one. It includes things like DMSA. It includes evaluations for renovascular hypertension and things like that. So it kind of covers everything. And so because of that, it also doesn't go into as much depth. The second one that they came out with in 2018 is specific for pediatric patients, and I'm not going to cover that extensively in this talk here. But then they do have this one that is dedicated to adults with suspected obstructive changes. So this one, if you're going to look at, and we have it available to you in the references, is very helpful because it goes into a little bit more detail on everything we're going to cover here now. So you can see there, they say avoid fasting, no special diet, arrive well hydrated. But on top of that, they go a little bit deeper. They recommend holding your diuretics the morning of exam. So if the patient is on chronic diuretics, you want to hold those. Same reason as you want to be well hydrated. You don't want them having, even if they've hydrated, you don't want them having urinated that out a lot before they come to your clinic. You want that there. And then above and beyond that, in addition to telling them to try to well hydrate at home, they recommend when they come to your clinic, as soon as they get there, they should take in orally anywhere from 350 to 700 cc's. Roughly, I base those numbers off the average 70 kilogram person that we talk about in medicine. So that's where those 350 and 700. Obviously, for a smaller person, it'll be a little bit on the lower end of that. A larger person, you need to take in a little bit more fluid. And similar to the prior ones, they talk about you catheterize the bladder only if they have difficulty voiding, and of course, make sure it's unclamped. You want that free flowing. So what about breastfeeding? It actually, in the guidelines, says there's no cessation necessary. But that said, other people chime in on this, and they also reference this in there and say, you may want to consider, and it's truly, they think, more for peace of mind of the patient. You can understand how a mother who's breastfeeding is going to be very concerned about radiation exposure to her child. And so here, if you look at the recommendations out of Europe, they say for MAG3, you should withhold breastfeeding for 4 hours, 12 hours, it's a DTPA. And then the ICRP publication just says simply express one meal after the exam and discard that before resuming breastfeeding. And again, though, doing nothing at all if they were to resume breastfeeding wouldn't cause any significant exposure to the child based upon estimates. So where did this data come from? I want to assure you that we're not just rummaging through your files here. We went through the IRB for this and gained approval to look at the anonymized data in the IAC nuclear database. This was all labs applying for a 1-3-year accreditation cycle from 2016 to 2018. This provided us with 106 unique institutions providing their diuretic renal scintigraphy protocols. And for those who have gone through the accreditation process, you remember you have to submit reports with that. And so we had 209 reports available. We don't have exactly 2 for each institution because some were maybe DMSA or something like that, so they weren't pertinent to this exact topic. And then we looked at 45 different variables depending on facility and staffing, patient preparation, exam technique, image processing, and reporting. And we will not go into all of these, but I do encourage you, if you happen to be attending SNMI this summer in New Orleans, we will be presenting this material in more depth in that forum. So you have an interest in. So facility and staff, we looked at the lab type, hospital-based versus outpatient, what's their exam volume, what's their GU exam volume, how many technologists and physicians, just to give us an idea kind of size and experience and things like that, to see if there's any trends. You know, is there something different about a high-volume institution versus a low-volume institution, how they're performing these studies. Then we looked at patient preparation, some of these here, exam technique and acquisition, image processing, and then reporting. And I'm going to tease out some of the highlights from these to talk about here on the next several slides. I will not go over them all in depth. So patient preparation. I mentioned the recommendations there: hydration, holding diuretics, breastfeeding, and bladder catheterization. You can see this is how we're practicing out there. The vast majority of us are making hydration recommendations to our patients, and I'll go into that a little more in depth, but we're not doing so good on some of the other things. Chronic diuretics, only 1/5 of us are making recommendations to patients to hold that. Now, I emphasize this is based upon protocols as well as research of reports. You know, certainly if you have a very astute technologist or administrator who's reaching out to a patient, they may be telling them this. It just may not be in the protocol. So we are a little bit limited in that, you know, the actual practice may vary somewhat from what's written in the protocols and what's documented in the reports, but we're only showing about 1/5 are compliant with that. Breastfeeding recommendations, same scenario there. And along with that, it is possible that some institutions have a separate protocol for handling breastfeeding patients with all of their studies that cover that, and we have not yet had a chance to look into that. So that number is probably higher than 26%, but it's probably not 100%. And then there are still some institutions out there, just 5, so about 5% of the ones that we looked at, that are recommending all the patients receive bladder catheterization. And that used to be the standard of care. But now it's really, like I mentioned, very young patients, neonates who can't void spontaneously, we catheterize them. Anybody else with difficulty voiding. And then the other time we consider it is if it's specifically requested by the urologist. We certainly want them to trust the results. So we'll let the patient know that their physician has requested that. And we're fortunate here in the inpatient setting, we actually can have them. We're hospital-based, so they can go by the urology clinic in the hospital, have that Foley catheter placed, and come down to us and do the study. Again, we let them know that that was at the request of their urologist. So what are the hydration recs that people are doing out there? You can see there that the vast majority, over 50%, are using oral hydration. That's great. That's totally acceptable by guidelines. Unfortunately, about 1/3 are not really specifying. It just, you know, and so where that comes from is that's basically institutions that says, you know, we recommend the patient be well hydrated prior to the exam. So it's likely that the vast majority of those are oral hydration. It's just not spelled out, but in practice, it's probably like that. But this can kind of give you an idea where your practice falls in accordance with your peers. You can see there's still a small percentage that IV hydrate all their patients. Not many, but just those 2 institutions. There's 7, though, that actually do both. They'll give oral hydration and then they'll IV hydrate during the course of the exam. Again, I'm emphasizing that it's not wrong. I'm just kind of liking to emphasize, you know, what's your practice compared to your peers, so you can kind of get an idea. I think it's very interesting to know how other institutions are performing exams. So, you know, one of the things we talked about early is the Society of Nuclear Medicine recommends arriving well hydrated and then having some PO hydration of at least 350 to 700 cc's. And this is what institutions are recommending out there. Some institutions actually recommend you take in a lot of fluid. That's not going to harm your study. It just may be difficult for your patient to do, but it's certainly only going to improve the quality. You can see there 1,600 cc's. A couple, though, are only recommending just under 250 cc, so a little too low. And then some don't make any recommendation on amount at all. They just tell the patient, just have some hydration, and that's it. Again, in practice, they may be giving more discrete guidance, but it's not in protocols or in reports that we can tell. So what this results in is that there's only about 2/3 of us out there who are complying with current patient preparation recommendations from our societal guidelines. So why is that important? Well, there are several patient-related pitfalls to these studies, and inadequate hydration is the first one that comes up. If you, again, don't have fluid available to mobilize, you're not going to be able to create enough urine to determine whether you have an obstructed versus non-obstructed situation going on. So to avoid that, you want the patient to be well hydrated. You want them to have oral hydration per guidelines of 5 to 10 cc's per kilogram, that 30 minutes to an hour beforehand, and hold their diuretics on the day exam if they're prescribed them at home. And then we'll talk about poor renal function here later. So how are we doing on holding diuretics on the day of exam? I hinted at earlier, we're not doing so well. Only 1/4 of us address it in our protocols, in our reports. Again, hopefully in practice, maybe it's a little bit higher than that, but right now we're showing poor compliance. And again, if the patient takes their Lasix that morning of, it could really kind of offset all of the work you've done telling them to get hydrated, because they've already urinated off maybe a couple of liters worth of fluid, and so they're actually arriving dehydrated to your clinic, or certainly not well hydrated. Poor renal function, if you don't have good kidney function, you can't respond well to the Lasix and can't increase your urine production. Because of that, there are recommendations that you increase the Lasix dose in those patients, and those are usually your patients who are on chronic Lasix. And reviewing the protocols of the 94, that should be 96. Only 21 out of the 96, so about 23%, 23% of us are addressing that factor. Right now, the current recommendations from the guidelines is that if they're on, the patients with poor renal function typically are on Lasix. So if they are on Lasix, you want to increase the dose to match. And certainly if they're not on Lasix, but they have abnormal renal function, the rule of thumb is that if your creatinine is elevated, that means you've lost probably at least 50% of your renal function to have an elevated creatinine, and therefore you probably need to double the Lasix dose. So with guidelines being typically 40 milligrams, you need to consider increasing that to 80 milligrams, and that's our approach here at our institution. So this is how the places that are doing it, the 21 institutions that are increasing the Lasix dose, this is how they're doing it. Some don't specify, they just say increase it. Others are referring, they're asking the physician who's on duty to, what dose do you want them to do? 5 are doing the same Lasix dose. Some have a sliding scale based upon the creatinine. Some have more of a kind of a fixed sliding scale. If it's 2 or greater, give them 60 milligrams, 3 or greater, give them 80 milligrams. And then some, you can see they're given 40 milligrams if creatinine is elevated, or 40 milligrams on Lasix. And again, the non-specified, they're probably referring to the MD, just saying, hey, how much do you want to give? Let me go back here one second. And one thing I want to point out is some of these are suboptimal. If you're only given 40 milligrams in the patient with an elevated creatinine, that's suboptimal. Again, you should be considering an elevated creatinine of giving 80 milligrams. 40 milligrams if on Lasix. Well, if they're on Lasix, they have a decreased renal function. Again, they might be best suited by giving 80 milligrams of Lasix. So looking at this, even though we have 21 institutions complying with considering increased Lasix dose, we really, it's more like 15% compliance, because some of these institutions aren't adequately increasing their dose of Lasix in the setting of renal failure. So it's always good to know what's everybody doing as far as radiopharmaceutical. You can use a couple. You can use MAG3 or DTPA. The guidelines don't come down hard on one or the other. Most seem to prefer MAG3 because it seems to do better in patients with poor renal function, and that is by far the most common being used out there by 2/3 of the institution, though there are some that are using both. Some using exclusively DTPA because it's probably, I would assume, because it's more readily available and cost effective. And then some institutions are using both, and those are ones that are typically looking at creatinine clearance and measuring that as part of their protocol. So How are we dosing? Well, this is a busy slide, but it goes to show there's a lot of variation. There's variation between whether we're using fixed dose, ranges, or weight-based approaches. And then within those subcategories, there's still a lot of variation. You can see here, fixed dose is by far the most common, about 80% of institutions using that. And then when we look closer at that, you can see the 10 millicurie dose is by far the most common among all institutions. So fixed dose more common than range or weight-based approach. And within the fixed dose category, 10 millicuries is by far the most prevalent dose amount used. I do want to point out down here in the lower right-hand corner, there are some institutions that are using ranges that go all the way up to 25 millicuries, and this is specifically for MAG3 when we were researching this. And it's important to know that all the guidelines out there recommend a max of 10 millicuries. So those institutions, may benefit from considering, if there's not something unique about their cameras or patient population, they may want to consider stepping those ranges down to 10 millicuries max. This is the values out there on average. For MAG3, you can see that we have 180 doses that we can look at, about 9.33 with a max of 15.9. So again, above that 10 millicurie guidance. And I wanted to point out here what we call the DRL and the AAA. Your DRL is your diagnostic reference level. That's the 75th percentile. So you can see it was 10.6. So 3/4 of institutions were dosing below that. So that's good. That's one of the ways we can kind of determine what's appropriate practices simply by doing a survey of institutions and kind of getting an idea and going off of that. And then the AAA is your achievable administered activity. That's the 50th percentile. And it's only a smidge lower in this situation, which goes to show that we're almost, the vast majority is, irregardless of what our protocols say, we tend to dose around the same amount. That's why those numbers are very close. We tend to dose around the same amount. We had a less robust data on DTPA just because it's being used less, but you can see similar, the numbers there are a little bit higher, which goes along with guidelines and things like that. What's interesting to point out is the Society of Nuclear Medicine, their most recent recommendation is actually saying we should try, again, it's not firm rule, but we should try to see if we can get our dosing for MAG3 down to 1 to 5 millicuries. And that's currently being done by only about 12% of our institutions. And I admit we're an outlier there. We have not made that change to that lower dose at our institution. We're still in the 5 to 10 millicurie range. So how about diuretic dosing? You can see here, same thing. Large variety between your fixed and weight-based, as well as some that are not even specified. The guidelines recommend 40 milligrams. So you can see here that the good thing is the majority of institutions are using that. But they do say you can use 0.5 to 1 milligram per kilogram. So these are also acceptable here. Although I asterisk this 16 because it's interesting that 2 of the institutions actually say use 0.5 milligrams per kilogram, but cap at 20 milligrams max. So kind of suboptimal. That's not a firm rule though, because the guidelines all do admit that if you have a young patient with good, healthy renal function, you still can get a good diagnostic study, usually with 20 to 30 milligrams. But a lot of our patients don't meet that criterion, so you may want to try to get up to that 40 milligram guideline. And my thoughts on that is certainly, my concern is if I gave 20 milligrams to a patient and I kind of got equivocal results, I worry I should bring them back and repeat at the standard dose of 40 milligrams to make sure that it's truly equivocal and not maybe normal and I just underdosed them with the renal Lasix. So this is pointing out the ones that comply with the EANM, the Society of Nuclear Medicine, the ACR guidelines on that. And again, 20 to 30 milligrams may be adequate in a young patient with normal renal function. But these ones here with the orange arrows, you can see start to fall outside that. We're suboptimally dosing a good number of our patients. What about timing? Well, this is probably the most variable parameter we have out there. You can see here it's all over the board. And there's a reason for that. The research has not declared one to be the optimal way. Whereas like gastric emptying, we have that nice solid gastric emptying protocol with 30 minutes, 1 hour, 2 hour, and 4 hour exam and a fixed meal. We're not there yet on diuretic renal scintigraphy. It's a place for more research and future action. You can see here The most common ones are a T of 0, giving the Lasix at the same time as your radiopharmaceutical, T plus 10, T plus 15, T plus 20, and then T plus 30. So there's a good sparing. But there's still a wide range of others in there where people are giving it at 2 minutes, 5 minutes, collecting system visualization. When the MD says, go ahead and give it, some don't specify. Important to emphasize, though, is the guidelines don't give a consensus on that. The Society of Nuclear Medicine, EAM, they list various protocols in their document, but don't say one is necessarily better than the other. And the same thing from the American College of Radiology and the Society of Pediatric Radiology. They have 4 listed in theirs and don't come down hard on one versus the other. It'd be an area I think we could improve, because I bet it frustrates our referring providers to see kind of such a variation in practice. So last topic I'm going to touch on briefly is reporting. Where are we putting our reports? Well, you can see here, diuretic timing, when we gave the Lasix. Only out of the 174 diuretic reports we had, only 60% of us were documenting when we gave the Lasix. Did we give it 15 minutes ahead of time? Did we give it 20 minutes after? Did we give it when collecting system visual? And that's very important information. One, for our referring provider to take into consideration, as well as for us on follow-up, because certainly the best follow-up will come if you repeat the same protocol, and you have to document that somewhere so that the person who comes behind you, when they, we always, our typical protocol at our institution, we use the F plus 0 in the vast majority, but if it comes from an outside provider and they've had a study from somewhere else, we defer to what the prior protocol said. So we get the report, and if it was F plus 20, we do F plus 20. If it was F minus 15, we do that, because we want to try to get the best direct comparison of our results to the prior results. Split function, how is one kidney functioning to the other? The good thing is the vast majority report that, but not everybody. Some just say, it looks normal or abnormal, and actually doesn't give a number in their report. And that's something that really should be in there. T1/2, it's not mandatory, but it's helpful information. About 80% of institutions are doing that. And then these parameters I list below that are getting reported infrequently are ones that are kind of coming up about in the last several years as being ancillary things to look for and report to help tease out these equivocal cases. The TTT is your time of tissue transit, or CTT is the cortical transit time. Void kidney to max, some people are doing that, where you, after patients got up in void, you take an image and you normalize that back to their peak activity. You can see there, those are being done uncommonly, but are being recommended by some researchers and some societies as being additional information you can use to kind of refine your interpretation and report. So why are these kind of novel things important? Well, I'll take you back to a case. You can see this patient here with colorectal cancer. They had this right-sided pelviectasis that was concerning for obstructive process. So they underwent this study. You can see that right kidney there. That right renal pelvis is dilated. It certainly has, it's asymmetric compared to the left kidney. We look at our time activity curve. It doesn't look like that first patient. Hers was, such a rapid upstroke and then a rapid downstroke. This one's very blunted, peaks late and it empties slow. You can see here, time from max to half max, ideally less than 10 to 15 minutes. It's 18, so it's kind of in a gray zone. I mentioned that you can do additional ROIs to further refine this data. We looked at the collecting system ROIs, and it actually got worse. It made us a little bit more concerned, because now it was indeterminate because it didn't reach T1/2 by the time we finished the study. So this is post-void image. Actually still made us concerned, because we see this abnormal retention of radiotracer activity in the collecting system. And this is where some of these ancillary data points can come in. Looking at your cortical time activity curve, this is really kind of goes hand in hand with that tissue transit time, or that cortical transit time. You can see here, this is a relatively normal looking curve. You can see the patient has a time to peak of well within that 5-minute range. So that's very reassuring. You look at the renal retention, it's below 30%. So this is suggesting that the kidney is functioning well, irregardless of how concerning that renal pelvis looks in that abnormal retention that we're seeing on those time activity curves. So what's going on here? Well, really, this is what that time activity curve is representing. It's representing that tissue transit and cortical function. So you see here, there's rapid uptake of activity in the parenchyma, but then it clears out very normal And so what's going on here is we just have a dialate collecting system. Even if there's maybe a low-grade obstruction, it doesn't matter because the kidney's not being harmed by that. This is normal, and so that's where these ancillary pieces of data can come in, like I mentioned. I'm going to wrap up there. So I just wanted to kind of, in conclusion, say that there's a high degree of variability in how we're doing our diuretic renal scintigraphy exams in our practice across the U.S. We're not really doing as well as we should with compliance with societal guidelines and parameters out there. There's a lot missing or variable elements to include things on patient hydration, dosage and timing of diuretic administration, quantitative parameters, and report content. And this could have an effect on the accuracy of the study as well as patient management, and because the results are going to be either incomplete or inaccurate. And so, I certainly see this as an area of possible improvement, looking at standardization and quality for what I think is an incredibly helpful exam and very valuable to our providers. So at this time, I'll turn back to Kelly or see if we have any questions from the audience. Again, I appreciate everybody taking time out of your busy day to be here, and I thank the members of the IAC for inviting me to talk.
Thank you very much. And at this time, we will begin the Q&A session. From IAC, I'd like to introduce Maria Costello, IAC Director of Accreditation for Nuclear PET. She will be assisting us with the Q&A session today. Maria, would you like to start us off?
Sure. Thank you, Kelly. So, Dr. Banks, the first question, do you also recommend the prep of avoid fasting for a captopril and diuretic renal scan for renal hypertension?
Oh, that's a good question. So, yes, and we do, although I have to, so on that hand, yes, we want that patient to, because it's similar, it's not exactly apples to apples, but we do, because of the same thing, we want them to be well hydrated so we can get a good renal scintigraphy. It's we're looking at different parameters, but a patient who, and it really comes down to that dehydration key. If they're dehydrated, your parameters are going to skew to the right on your time activity curve, which means you're going to elevate things like your time to peak and your tissue transit times and things of that nature. And you could give yourself a false negative would be more likely the case in your captopril study.
Okay, thank you.
I hope that's helpful. I have to admit, I admit we do those very infrequently at our institution. The vast majority, number one is renal scintigraphy for obstruction, and then number two is DMSA looking for things like pyelonephritis and scarring.
Okay, thank you. Next question. When you have an obstructive pattern pre-Lasix and then a non-obstructive pattern post-Lasix, for example, the dilated system drains, is it safe to say in your conclusion that it is a non-obstructed kidney, however drainage is impaired?
Yes, it's similar to the verbiage we use in our reports. Yes, it's a great question. There's a gentleman, Dr. Savaknianakis, I may be mispronouncing it. It's a Greek name. He's down in Florida, and he does about 6 of these a day. He has a wonderful practice pattern. But yes, we will say there's, we use something to the phrase of there's delayed emptying of the collecting system. However, there is no obstruction. And we emphasize too in our impression that there's, no parenchymal impairment, split functions normal, tissue transit, things of that nature. So yes, as long as you respond adequately Lasix and it clears out, you can say very definitively no obstruction. And I think the urologists, the ones I've worked with at several institutions have found that to be very helpful.
Okay. Some centers give 250 cc hydration 30 minutes before the exam and then inject the MAG3 through the IV. Any thoughts? Well,
I guess so. First, we want to make sure that they've done some supplemental hydration on that, because we talked about if you're the ideal 70 kilogram person, you need at least 350, and that's on the low end. More really about half a liter of hydration. So 250s. Low on that. Injecting through that same IV line, that's an interesting question, because that's why I find practice patterns so fascinating, because I've only practiced at half a dozen institutions, maybe talked to colleagues from another half a dozen institutions, and so sometimes these scenarios haven't come up, so I haven't really contemplated them. I cannot think of any reason that would be a problem, as long as you flush. Yeah, I don't have experience with that. Off the top of my head, I don't see a problem with that. I'd want to bounce that off a few other people to make sure I'm not overlooking something. But no, I don't know of a problem with that.
Okay.
I'm sorry, I don't have a definitive answer.
Okay, so this next one has multiple parts. When do we say a kidney is obstructed, and when do we say there is impaired drainage? Which study is preferred to make a diagnosis of obstruction, a 40-minute uninterrupted dynamic study, or a pre-Lasix 20 minutes and another 20 minutes post-Lasix?
That's a great question. So here, nobody has come down hard on that, and that's why this is so challenging. Why a lot of this kind of lets you see how people practice at different institutions. My approach at my institution is I kind of look for mounting evidence. The first thing I looked at is there a delayed T1 half? Either, is it slow to emptying out a collecting system? And I teach the residents, greater than 20 is where I start to think about obstructed. But greater than 15, you need to kind of go through the same thought process. So that's the first piece of evidence: delayed collecting system emptying. That said, if it's really dilated up, even with Lasix, you still may not get a normal T1 half out of that. Or if they have underlying chronic kidney disease or they're dehydrated, all those things could give you a falsely elevated. So that's why that's only the first piece of information you look for. And the next thing I do is I look at my post-void. If everything looks great on the post-void, at the conclusion of the study, you have the patient get up, walk around the clinic, let gravity come into play, have them void, and take another image. And if it's cleared out, then I feel reassured. I feel very reassured. Then the last things I look at is how's my tissue transit time. So I look at that visually. If the parenchyma is clearing out, then there's no dysfunction. If I have a rapid time to peak on my cortical time activity curve and it empties out very rapidly, that's essentially your tissue transit time. The way tissue transit time is defined in the literature is basically if you don't see activity in the renal pelvis all the way between your second and your eighth minute, and that implies that you have delayed tissue transit time, and combined along with the fact that you visually don't see a significant decrease in parenchymal activity following 3 minutes. So I use my time activity curve. That's the cortical time activity curve, but you can, a more simplified way is visually look for a photopenic renal pelvis. If it still has no activity by 8 minutes and you're not seeing a significant washout of the parenchyma, that's delayed transit time. If that's present, that would be very supportive of the fact that you have obstructive pathology going on. And then the last thing I look at is my split function. If I'm still on the fence and my split function is normal, and I don't think there's a bilateral process going on, then I will tend to be conservative and say, this could be obstructed. However, if it just doesn't, not everything's falling into place, I'll say, the split function is normal, so we could consider doing a follow-up exam in 3 to 6 months. We have time because we're not losing function that we can measure at this point in time. So that's how I do it. As far as which protocol is best, there's a lot of debate on that topic, because, but for looking for obstruction, it's probably where some people would argue that's the 40-minute one, where ideally to best exclude obstruction is you want to actually kind of go back to the old original, the Santa Fe consensus, they called it, where you watch for the collecting system, you take it out to 20 minutes and see if you have max activity in that collecting system. And even if if you think it's still increasing at that point, you wait a little bit longer until you have that max activity in the collecting system of concern and then administer the Lasix. Because while the F-15, where you give the Lasix 15 minutes ahead, or the F equals 0, like we do at my institution, where you give it at the same time, those, while they will help you get rid of some of the equivocal cases, there is a chance that you could get the kind of the increasing nephrogram pattern in some of those cases and have a false positive. So some of the researchers say while those work very, very well in the vast majority of patients, those few cases where they have dysfunction of that kidney, it takes a long, long time for it to fill its collecting system, you need to wait in those situations. So that gets tricky. We have had a few situations at our institution where if we think our F equals 0 protocol wasn't best and we don't realize that until after the fact, we'll talk to the urologist and see, how concerned are they? Do they want us to bring them back and repeat the study and wait until max collecting system activity?
Okay, thank you. I think that's all the questions we have time for today. So I'm going to turn it back over to Kelly.
Okay, thanks again, everyone, and a very special thank you to Dr. Banks for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Diuretic Renal Scintigraphy in 2020, where we are. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and any time thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.